morning, good evening, good afternoon, wherever you are, and welcome to this webinar, Building a More Resilient Healthcare Workforce, Strategies to Enhance Vaccination Uptake Amongst Health Professionals. And my name is Michael Moore. I am a past president of the World Federation of Public Health Association, and I have the honour of chairing our International Task Force on Immunisation Policy. With me, I have three speakers who are going to assist the discussion this evening. The first of those will be Raymond Hudibasi, who is a health economist with over 30 years experience in immunisation, vaccines, biological, and works with the WHO. He holds a PhD in health economics from Erasmus University in the Netherlands, and has a most amazing CV. By all means, go online and check it. Then after him, we'll have Dr. Ivan Ivanov, who is both a medical doctor and a PhD, and he leads the WHO's occupational workplace health initiatives, developing policies, norms, and standards, providing technical assistance with country. For many countries, his focus, although a background in medicine, it will be on occupational health and safety and occupational health and sociology, by which he aims to create safe environments. Dr. Philip Laymbach, also a medical doctor and a PhD, works at the World Health Organization Department of Immunization, Biologicals, and he's the Executive Secretary of the organization's immunization and vaccine related areas. So it's going to be my pleasure to introduce the first of our speakers. But before I do, I want to note that we're also using tonight to launch our report of the same name, Building a More Resilient Healthcare Workforce, Strategies to Enhance Vaccination Uptake Amongst Health Professionals. There is a link in the chat area for those who are now watching, where you can get your own free copy of that report, and where you can find sensible ideas to be able to pursue. Before I start, I'd also like to acknowledge the support that we have from the University of Geneva, from Pfizer, and from the World Health Organization. We have support of the World Health Organization having you guys here, but the support for the webinar from the World Federation of Public Health Associations. My final acknowledgement is that I live and work on the lands of the Ngunnawal people in Australia, and I pay my respects to the elders past and present. It's now my pleasure to introduce Dr. Raymond Hudibasi to give us an overview of this issue around resilient healthcare workforces. Raymond.
Yes. Thank you, Michael, for the introduction. And thank you also for inviting us from WHO at your webinar. And so I'll give a short introduction on the work I'm leading in a small team in the immunization department in Geneva, which is called the Value of Vaccines. And in particular, a concept we have developed over the last couple of years with regards to the full value of vaccine assessment. And Philip, my colleague, will then also follow up with the work he is doing on the full value of vaccines. So next slide, please. So just to remind you that this year we are celebrating 50 years of EPI, the Expanded Program of Immunization. It was introduced in 1974. And also in our team, we have looked actually what the benefits were from 50 years of EPI vaccines. And in a recent publication earlier this year in The Lancet, we estimated, based on mathematical models, that vaccination has averted over 150 million deaths and accounted for 60% of decline in global infant mortality. And also with regards to the Immunization Agenda 2030, we have these same analytical tools to, estimate if member states of the WHO would reach those aspirational targets in 2030 with not only EPI vaccines, but also live course vaccines like HPV, influenza vaccines, and other vaccines in the 2030 target. What would that bring? What would that bring us in terms of that averted? And again, here, this is another publication we had last year. If we would reach these aspirational coverage targets, it would save us more than 50 million of deaths, of which a majority of these deaths are from measles vaccination. Okay, so again, back to the 2030 immunization agenda. It's really the concept of WHO working from a universal health coverage perspective, where we would like to have these vaccines out there from an equitable uptake. So no matter where you are, who you are, and at what age, you should have full access to these vaccines. And it's not only for health, but also for well-being, so broader than health. And that is relevant to the work we're doing when it comes to assessments. And Philip and I will go into that. But also that these vaccines should be taken up in countries that are country-owned. So the policy making, the priority setting of vaccines in countries of live course vaccines should be owned by countries. So next slide, please. So what we actually do from the global level in our team is, when you look at the challenges of vaccine development to uptake of vaccines, and here I've simplified this with the two gaps from research development to licensure, what I would call the translation gap, and from licensure to uptake, the introduction gap. That we need to find the resources to move promising candidates from preclinical research into product development, but also that those vaccines that first reach licensure might not always meet the most need, in particular in low and middle income countries where most of the vaccine preventable diseases are the highest in terms of disease burden. So, and often what we also have experienced in the last 20 years, more than that, when vaccines have been developed, often with a high country market in mind, which offers, of course, near-term return of investment. Also, that the problem with that is that product preferences can differ between high-income countries and low-middle-income country markets, not only in terms of strain coverage or duration of protection, but also, for example, storage conditions, but also price tolerance, an obvious one. Of course, this also needs to be taken into account when new vaccines are being developed. And then the criteria and processes for recommendation and financing differ between high-income countries and low-income countries, in particular for the last bit, the uptake, where many countries, especially when they graduate from, for example, Gavi support, then need to find the domestic resources. So what are we doing in our team, and in particular in the value of vaccine assessments? So we try to identify the technical roadmaps and the preferred product characteristics of the ideal candidates of vaccines that meet the needs in countries. We come up with these vaccine profiles, but also do this for what we call full value of vaccine assessment, which are a holistic assessment that provides the value of vaccines to the different stakeholders involved in the vaccine pipeline development, with the idea in mind that we don't want to delay, of course, unnecessary delay because of stakeholders are not aligned with regards to the value of vaccines, but also having those vaccine products out there which meets the country needs. So we're doing this actually in our team in normative work by standardizing evaluation and the communication of vaccine value, and so across the different vaccines to measure the vaccine impact, and not only in terms of what I said earlier in the introduction on health, but really looking also at the broader benefits, also the impact of of vaccines, for example, to the working population, the savings to society, and even linking this to macroeconomic effects in outbreak or pandemic situations. And important here is that we align the stakeholders involved in vaccine development across the vaccine development pipeline on their priorities. So let me hand over to Philip, who will then continue with the value vaccines we're doing in our team.
Yeah. Thank you, Raymond. Just before we do, I'd prefer to just go to Ivan and get his reflection on the role vaccines play in terms of occupational health and safety, and then come back to Philip to round off. So if I can now invite Ivan to discuss those issues for us, please.
Okay, great. Thank you very much first for inviting an input from occupational health and safety about the vaccination of health workers. I really appreciate your invitation. And I would like to share some thoughts with you, but before I start, I would like to acknowledge the contribution of my colleagues from the WHO team on health worker vaccination, in particular Kathleen Polito and Stephanie Shandale, in preparing for this webinar. Now, why we need to vaccinate health workers in particular? Why not just vaccinate the whole population and everybody will be healthy and safe? Well, first, vaccination of health workers is crucial for several reasons. It prevents the spread of infections in healthcare facilities, ensuring the safety of patients, protecting the health and safety of health workers themselves, and additionally, maintaining a healthy workforce is essential for the effective functioning of the health system. So nobody has interest in keeping workers on sick leave because of disease, and they wouldn't be happy as well. Next slide, please. Now let's see what WHO recommends. WHO recommends developing national policies on health worker vaccination that specifically align with the national vaccination schedule and the WHO position papers on the vaccines. Specifically, there is table 4 of the WHO position papers outlines which vaccines WHO recommends specifically for health workers. These policies should be included in the occupational health and safety programs at the national, subnational, and facility level. And together with the ILO, we have developed a specific guide, Caring for Those Who Care, on how to develop such programs and how to implement them throughout all levels of the health system. And the full implementation of the vaccination policies for health workers is essential. So for this reason, WHO has developed an implementation guide with some good practices and tips on how to implement such policies. So we can share the links in the chat to these documents. Next slide, please. Now, what is the role specifically of occupational health and safety programs? Such programs are developed at the national and then rolled out subnational and facility levels, and they aim at protecting the health, safety, and well-being of health workers and protecting them specifically from occupational hazards. The immunization of health workers should be embedded in these programs in all levels. And the key elements of such occupational health and safety programs at the facility level include having a facility focal point for occupational health, a warm body to make sure that things happen, and competent also, ensuring environmental hygiene and sustainability, establishing joint labor management committee for health and safety at work. And other important aspects are the assessment and mitigation of occupational hazards, information, education, training. Immunization of health workers is a key component of the occupational health and safety programs, together with the early detection, diagnosis, treatment, care, notification, support for occupational diseases and injuries, recording investigation and reporting of incidents and monitoring the evaluation. And the next slide, please. So what are some of the keys for a successful immunization of health workers? First of all, effective immunization of health workers involves including vaccination of in the occupational health and safety programs and plans, as I mentioned. This should include the routine vaccination, the seasonal vaccination, the vaccination against specific pathogen if there is an outbreak of diseases which are preventable through vaccines, and vaccination against diseases for which health workers have an increased risk, for example, hepatitis B. And it is also necessary to implement strategies that have been effective in promoting health worker vaccination. And these include policy directives, standard operating procedures, accountability mechanisms, making vaccination accessible and convenient, providing incentives, raising awareness about the need for vaccines, reminder systems, leadership, institutionalizing activities into pre-service and other training opportunities, and implementing soft mandates. It is extremely important to monitor and create registries and other mechanisms for tracking coverage because the estimates of coverage are not reliable. So with this, thank you very much and happy to answer any questions should you have.
Trying to find my unmute button. Thank you so much, Ivan, and you've raised quite a number of really interesting questions, and I really like the framing of this issue in terms of occupational health and safety and the protections there. So we've listened to Raymond talking about the full value of vaccines in the community, looked at occupational health and safety with regard specifically to healthcare workers. And now I'd like to hand over to Dr. Philip Lambach to take us through to the next stage. If I can ask you to do that, please, Philip.
Thanks so much, Michael. And what I'm going to do now in my part of the presentation is actually bring the two previous presentations together, because Raymond, Ivan, and I had been actively working on let's say some guidance that brought together the health worker and occupational health world together with some work that led ultimately to the full value of vaccine assessment work that we are doing now. So next slide, please. So here we have an overview of what the Strategic Advisory Group of Experts on Immunization, the key WHO advisory body for policies that relate to vaccination, provide as advice for health worker vaccination on the left. We see that quite a number of antigens are covered in so-called WHO position papers, where we outline everything that's relevant to formulate a vaccine policy at national level. So the global level provides these position papers, and then the countries can see how they translate them into their immunization programs in national policies, guiding ultimately health worker vaccination from their end. On the right-hand side, you see already Ivan has shown the implementation guide for vaccination of health workers, which was a key, or is a key document to ensure that the policies that are shaped through the position papers on the left get translated into action in countries. And the document that was underlying this implementation guide for vaccination of health workers on the right, that was like the initial nucleus, is on the very left. And this is where Raymond and I, who led this effort, the guidance to develop the guidance on how to implement seasonal influenza vaccination of health workers, worked together with Ivan to make sure that influenza vaccination specifically is provided in an effective way to health workers in countries. Next slide. So that's a bit of a lot of text. I'll summarize it verbally. This is an excerpt of the latest WHO position paper for influenza. And this position paper provides the rationale for vaccinating health workers. The sequence of the risk groups in the top paragraph is not prioritized, so the health workers are not the most important group, but one of the several groups that are considered as relevant to be vaccinated against influenza. The seasonal influenza vaccines that are currently in place have demonstrated benefits over no vaccination and may therefore be considered for vaccination of health workers. Primarily not to protect the health workers themselves if they are fully healthy, but more due to the fact that they have a higher risk to be exposed to influenza and can also transmit the disease to patients that would be vulnerable. The reviews that were conducted for influenza vaccine also saw that that influenza vaccination can be cost effective for health workers and older adults from a societal and an employer perspective, primarily in high-income countries. For low and middle-income countries where who are considering mainly to introduce influenza vaccine, however, the evidence remains limited. And that's a problem because, as Raymond mentioned in his presentation, we want to achieve equitable access. Next slide, please. And equitable access is a problem. The current seasonal influenza programs are challenged in countries as current vaccines have a moderate efficacy. They need to be matched every year to circulating strains and new formulations come out that need to be reintroduced. So every year it's as if a new vaccine is being introduced in the countries. And this is also another problem is their limited duration of protection. So countries that have several peaks for influenza vaccination automatically come into logistical issues. In current seasonal influenza vaccines are, however, important to be used in all the countries equitably, because if a pandemic occurs, it was found out that after the swine flu pandemic in 2009, that the countries that had seasonal influenza programs in place were able to respond much quicker to the pandemic outbreak. So seasonal influenza vaccination programs that are in place in low resource settings are critical when it comes to a pandemic to beef up vaccination programs and protect populations against the pandemic. Obviously, that comes with a high investment every year. So where money is limited, vaccinating healthcare workers as, let's say, a transmitting and a vulnerable group in case of a pandemic that needs to stand in line and be functional during pandemic outbreaks, health workers are seen as a key target group across countries to be vaccinated as, let's say, the minimal common denominators across countries. So what can be done against this lack of introduction of vaccines? Next generation's vaccines can be developed to overcome these challenges. And this is why the immunization program has joined forces with the pandemic department in WHO, WHE, I'm sorry for all the abbreviations at the last paragraph, to develop a full value of improved influenza vaccine assessment. And I'm going to quickly explain what this is about. Next slide, please. So you see on in this blue arrow, the vaccine development continuum. On the left side, the vaccine is being developed On the right side of the arrow, it's being implemented in countries. And in between, we have all the different stages: policy development, regulatory clearance, financing considerations for use in countries, introduction of the vaccine, etc. Above that are 4 hurdles where we can see that this continuum can be affected. And the hurdles are linked to, at the bottom of the slide, we see several questions. Click please again, where we can see that let's say vaccine developers on the left are wondering whether they should invest in developing the vaccine, asking whether there's enough market demand. Then in the middle, policymakers are asking whether they should recommend vaccine. And here we have the structure of the FEVA that aims to respond to all these information requests from the various groups. On the left, we have the synthesis part, which is explaining the global need for a vaccine, showing what the research and knowledge gaps are. In the middle, we have the vaccine development narrative, which is primarily important for the first gap that I just described, for the vaccine developers. Does financing the development of the vaccine make sense? And on the right side, we have the part that is most relevant for countries that describes what value and impact the vaccine would have for all the stakeholders down that vaccine continuum. Next slide, please. This is an example of another vaccine that is already published, the Group B Streptococcus full value of vaccine assessment. What you see on the very left column here are the different elements that this full value of vaccine includes. In white, we have the, let's say, disease burden estimation, the impact estimation of the vaccine, and understanding the market for the vaccine. And then in the next column, the findings and what is actually coming out of these findings. And in gray, we have the economic aspects that actually provide funders with an idea of what is needed to fund this vaccine, and do I get my money back for developing this vaccine? And at the bottom in dark gray, we have the summary and recommendations for all the different stakeholders. And what the FEVA does, that it does not only synthesize the evidence, but on the right column provides also advice to the different stakeholders, vaccine development funders, and implementers in countries of what needs to get done to make a vaccine work. And for health workers in countries in specific, that means how does the vaccine get implemented so all the health workers can be covered. Next slide, please. When does an FEVA get implemented? It usually comes in when the vaccine is still being developed. It can also come in the case of influenza when the vaccine is already there and we are considering, let's say, an update of the vaccine in the future. So here we are really talking about next generation vaccines that could help address the issues of current influenza vaccines in place. FEVAs can be updated, they're dynamic and can be changed over time to be always able to inform policymakers and implementers in countries so that they have always the latest evidence available to inform their actions. Next slide. What happens after an FEVA has been developed? You remember the right column that I described previously on the GBS full value of vaccine assessment. Advice is given to the various stakeholder groups to work together on the vaccine development, because those gaps that threaten the quick development of vaccines and funding of vaccines and implementation of vaccines, they get addressed better when the stakeholders are working together. The vaccine developers and the funders need to discuss plans on how the development of the vaccine and the introduction can get funded. The policy makers need to know what the market of the vaccine needs to be and discuss with funders how this can be rolled out in low resource settings when countries don't have enough money to roll this out, etc., etc. So those are the questions, or those are the activities between the stakeholders that the FEVA furbishes. And finally, how does the FEVA translate into countries? There's a multi-criteria decision analysis that should take place in countries that are considering the introduction of a vaccine, so that the stakeholders in the countries can decide on whether they would use such a an approved vaccine or not. Next slide. And this is ultimately how it's done. WHO helps countries to organize country-level stakeholder workshops where you look at the evidence from the FVVA and you discuss the programmatic barriers we have in the countries of how to, in this case, reach health workers with influenza vaccine, and what the barriers could be in terms of acceptance on the vaccine, in terms of perceptions towards the efficacy of the vaccine, what the overall attitude of the health workers could be to use the vaccine in countries, etc., and also what the financial means are to support the use of the vaccine. And this is just a summary slide that summarizes what I've said. I'll pass back to Michael for sake of time. I believe you're on mute, Michael.
You'd think I'd get used to that by now. My apology. So one of the things I'd like to do then is to bring each of our speakers back and begin with a broad question for Raymond. Raymond talked about health and well, but let me apologize first. There was a question earlier. Do we have this translated into French? And my apologies, we do not have it translated into any other language at this stage. We had you mentioned health and well-being in terms of your full value of vaccines. But at the same time, one of the things that our report has really emphasized, and I think you touched on it, is the unique social, cultural, political, and economic circumstances from one country to another. How do you take that into account when you're looking at the full value of the vaccine for a specific country? And now you're on mute. It's your turn now after I set the standard.
Yeah, my apologies. Yeah, so great question, Michael. And this actually builds on what Philip just presented. As you rightly say, every country, all countries are kind of different and have their own context-specific values, and but also health systems are different in terms of the absorption of vaccines, the way they deal with the acceptance of the vaccine, the willingness to pay. All these kind of different issues are very context specific. So what we do in our team is, in particular for these the full value of vaccine assessments, is as well as Philip presented at the global level, informing the different vaccine attributes that the different stakeholders across the vaccine development pipeline need, all the way to the uptake of vaccines in countries. But also, as Philip presented, we organize these workshops where we do have evidence for the different criteria countries might find important, including the distributional effects of vaccines, for in the uptake. It could maybe deal with the socioeconomic differences, filling that gap in terms of health by, in terms of, for example, what Philip presented on the influenza vaccines. And so with these country level workshop we organize, we try to facilitate really having countries country-led uptake of vaccines, because without this broader stakeholder workshops and also a recognition of the value of a vaccine in a country, it's very difficult to move the needles in countries in their uptake, and including having the value of vaccine assessment information we provide more as a input to the deliberations in terms of decision making, whether countries would like to uptake, but also the different target groups in countries could also use these assessments in order to inform their own decisions. I don't know
Sorry, Raymond, how closely do you work with the national immunisation, the NITAGs groups, in order, because we're talking about broad consultation, but of course, in the end, the decisions made as a recommendation from a NITAG to a political politician, and that's when we get our outcome. So how do you work with the NITAGs?
Yeah, sure, Michael. And yes, the NITAGs are our first entry point, as though they do have the expertise on vaccine, the science of the vaccines, the latest evidence of vaccines. But it also again depends on the country who are involved in vaccine decision making. And we recently had a workshop in Indonesia where they were planning on their new national immunization strategy from 2026 to 2029. The NITAG was indeed the core group who was present at our workshop, but then they also invited, because they were also discussing malaria vaccines, dengue vaccines, they are inviting, for example, disease control programs within the ministry, but also international stakeholders, NGOs who are involved in the uptake of vaccines can also help the country in terms of the uptake of the vaccine. And I have a kind of a, as I said, I use the term the country-led and owned priority setting of vaccines.
Yeah, look, thanks very much. That's clear. I see I've got a hand raised for Ndiago. I'll go to you and allow you and invite you to put your question. And then I will go to Ivan because I have a question for him. So, Ndiago, would you like to present your question? You are on mute at the moment. I see you've come on, but you are on mute. Ndiago. I'm just going to give you one more little try to ask your question, but you do have to take yourself off mute. In that case, I'll while we're waiting, we can come back to that question. I'd like to go to Ivan, and I'd like to ask you the question, Ivan, about using vaccination in occupational health and safety thinking. Which countries are leading in this area, and how common is it for countries to have already adopted this very important approach?
Thank you very much, Michael. Well, with regards to the countries leading, I do not have in front of me a list of those, but I can tell you that it's about 40 countries that already have national occupational health and safety programs for health workers. We do monitor this through a WHO indicator. So every year we do intelligence and surveys to find out which countries have developed such programs, and then validate the answers to see whether the programs and documents they have developed really are occupational health and safety programs for health workers. You're asking a very good question about the inclusion of vaccinations in these programs. And I think with our vaccination colleagues for health workers in the immunization department, we did look into the existing national programs. And I think we do have ideas about which countries have included specifically the vaccination of health workers in their programs, but I do not have the list in front of me to tell you.
Yes. Yeah, and look, I suppose a follow-up question, certainly from my own country, often these sit within the next level down jurisdiction, the states and territories, in Canada, the provinces, the United States, the states, and so on. And in fact, in some ways, it's probably more important than having them at national level to have them at the next level down. Do you monitor that, or do you work nationally as the World Health Organization?
Well, as a World Health Organization, we monitor the national implementation, but the guide that we developed together with the ILO for the development and implementation of programs for occupational health and safety for health workers, there are specific sections for national, subnational, and facility level. Knowing exactly that in countries like Canada is also another example, other countries, India, where the subnational authorities, provinces, states, they have the implementation function. And so it depends on how the country is organized. But they can take everything from the guide.
Ivan, one of your colleagues has also come to provide a little bit of information in the Q&A. Shoshana Golden from WHO points to a recently published article which provided information on which countries have national policies for vaccination for healthcare workers, and she's got a link. However, that's not the question I was asking, which is in the context of the occupational health and safety legislation, which is a slightly different matter.
Yes, certainly the occupational health and safety legislation has enormous leverage for implementing practical implementation of the vaccination. And in many countries, the legislation for occupational health and safety would include also the prevention of infections among health workers and the use of vaccination of health workers. Now, whether it is mandatory, whether it is voluntary, and what kind of measures are taken, this is extremely country specific. But it is our recommendation that the legislation, the programs, everything on occupational health and safety should aim at vaccinating health workers, at least providing the access to the vaccine. But I want to say here that certain countries, for example, I'm aware about Sierra Leone and Gambia, other countries, there is a very, very severe shortage of vaccines, particularly hepatitis B vaccine. And though they want to vaccinate their health workers, they do not have the vaccine. So they are relying on Gavi and other mechanisms to get the vaccine, but the mechanisms in Gavi are still not available to prioritize the vaccination of health workers.
Yeah, it is interesting. I'm going to go one more try to, and I hope I'm pronouncing your name somewhere towards Njahu. You've had your hand up, and you've come up onto the screen for me. Are you able to come off mute to make your comment or ask a question? All right, so we'll let that one go. One of the things that's also interesting to me in our report, we broke down the influence we use for healthcare workers into three levels: into entry level, into mid-level, and then to advanced level. And in each of those, we have 8. In the first two, we have 8 suggestions. The first ones at the entry level are easy ones. They're about reminders. They're about education. They're about lectures. And as we go further in, we talk about involving international bodies, about on-site vaccination, mobile vaccination carts, and so on. I wonder if I can bring Raymond in. I've got Raymond. I wonder if I can bring Philip in and for any of you to comment on how important is it to have as many of these ideas working together in order to get the best possible outcome in terms of reaching healthcare workers and getting, if I would say, a professional approach to vaccination.
I think you'll only have to add another hour to respond to that question. It's very complex because in every country you have different situations, and also different, let's say, healthcare worker networks. You have in terms of acceptance and attitudes of influenza or of vaccines in general. There's really a varied, let's say, carpet of opinions. And I put in the chat the last publication that I put in is a literature review of the determinants and barriers to health worker providers' recommendations to pregnant women. And that already shows how complex the perceptions are with regards to vaccine safety, the disease burden that influenza actually poses, the safety considerations, and also the effectiveness of the influenza vaccine. And this is just the influenza vaccine. When we think of hepatitis and the other vaccines, I'm sure that Stephanie Shandell from WHO can talk much longer about that. Ultimately, each country needs to, in this multi-criteria decision analysis, understand what the situation is with health workers. And we have a very good guidance from the European Office of WHO that helps countries actually evaluate this and then adjust their vaccination program so that it optimally gets implemented among health workers. I'll try to put this in the chat a bit later.
Yes. Look, thanks very much, Philip. And I think that I'd like to take from that one of the early statements that Raymond made about measles. I don't remember the number of deaths, a specific number of deaths. I'm very conscious of the case in Samoa, where there was a breakdown in vaccination, and then we had, out of a population, my recollection of Samoa has 450,000 people, something like that, and yet we had 80 babies die through lack of vaccination. I'm going to be political here because I can be, and Robert Kennedy Jr. was one of the people who went to Samoa to discourage people from vaccination. And I realise my World Health Organization colleagues can't comment on this. I'm in an NGO, I can, and I think it's an appalling case that should at least make people think twice. Let me come back to my question. It was an aside. With regard to measles specifically, there's not just the protection of the healthcare worker, but there's the protection, particularly if they're dealing with young children or babies. How much does this come into your thinking when you're doing the full value of vaccine assessments?
Yeah, maybe I can start, and maybe you can fill up.
Please, Raymond, I did mean for you to start.
Oh, sure. In these assessments, where we also look at the transmission rate of the specific vaccines, we also use these analytical tools, as I mentioned earlier, for example, mathematical models, to also estimate the indirect effects of vaccines, through the herd immunity of vaccines. And this is definitely something that needs to be taken into account in these assessments. And I don't want to make a special plea for vaccines only, but any other health interventions that might have offsets, that should be valued. And it's ever also in the IA 2030 agenda, not focusing on health only, but on well-being. So the societal benefits of vaccines is really important to emphasize, because in the end, it's really the individual who has to see and kind of needs to see the intrinsic value of a vaccine. And it's very difficult, to push this through the throat of people in order to accept. It should be part of their, the tools they have to actually have a happy life, a good life. It's and to demonstrate these indirect effects, the broader effects, not only for yourself but to society. I think it's very important, and should also be captured. I don't know, Philip.
asking this, when you're doing your full value assessment, are you taking into account adverse incidents? Because they do occur. I've often argued that adverse incidents are minuscule compared to the nature of the disease, but they do occur. Do you take that into account in your valuations?
Yes. So I can also start with it. Again, referring to the country workshops we organize, what we often see is that countries also take that into account when they prioritize vaccines or considering vaccines to be taken up in the national immunization program. So really looking at the adverse events kind of criteria is definitely something countries want to consider, and hence also WHO provides all that information, in particular also from the SAGE. Philip was referring to us, the Strategic Advisory Group of Experts on Immunization. That is definitely something we also put on our websites, transparent about this, and also ask countries also to, and also the members to take that into consideration in the global recommendations, but also what we also share with NITEX, etc.
What I'd like to do now is to go first to Philip, then to Ivan, then back to you, Raymond, and ask you to give us a short take-home message that you think is important before I do the formal launch of our report. So can I start with you, Philip, a short, sharp take-home message, if you can do it?
Well, the short message would be health worker immunization from a value perspective is not yet well understood, but this question will be one of the key questions to be answered over the next years. So the key question would be, does an assessment of the full value of health worker vaccination make sense? In brackets, probably yes.
Okay. Ivan.
Yes. Recently, the International Labour Organization has proclaimed that safe and healthy work environment is a fundamental principle in the right at work for all workers. So the vaccination is a tool that helps to protect health workers from vaccine preventable diseases, as the masks and other personal protective equipment also applies. It is also personal protection, so that is the reason also of linking the vaccination of health workers with occupational health and safety regulations, policies, and programs.
Yeah, and the provision, of course, of appropriate equipment, personal protective equipment. Indeed, yeah. Thank you so much, Raymond. The final statement from you.
Yeah, thank you, Michael. And I don't want to be the final word, but I think it's really in general, and also what we try to show with these with the value of vaccine assessments we're doing in our little team, but also with a lot of institutes and academic institutes we collaborate with. Eventually, it's also applies to health intervention in general. That it is not this investment in vaccine is not kind of a short-term cost, but really a long-term investment. And this is something also relevant for health workers vaccination.
And here's the first one. This is what our report is: key strategies for overcoming vaccine hesitancy among healthcare workers. And what we're interested in doing is reaching out to our member organisations, to academics, to those involved in politics, decision making, to say, here are some ideas. They're just some ideas on how to influence others to implement strategies for overcoming vaccine hesitancy amongst healthcare workers, because of the impact, as we've heard tonight, that it will have not only for healthcare workers, but also, of course, for the community in general. And for my final slide, if I can, Maria, I just want to say thank you very much. This will be available on YouTube. Thanks again for the support from the University of Geneva, from Pfizer, from the World Federation of Public Health Associations, and particularly tonight from the World Health Organization, from our three speakers, and the other comments that have come in, because I think that our relationship, our formal relationship with the World Health Organization is one that we value very, very highly. And we hope that we can continue to be supportive of the amazing work that you are doing, and that we can continue working together. So to each of our speakers, thank you very, very much. And for those who have been engaged tonight, we appreciate it.